Thank you. Today our guest is Dr. SUBHRANIL SAHA, MD Homeopathy, MD Dietetics and MBA Healthcare, Lecturer, Department of Repertory, Dr. D.N. Day, Homeopathy Medical College, Calcutta. Editorial Board Member, Homeopathy. Publication metrics, publications 122, citations 382, index 17. Is working as lecturer in the Department of Repertory in the D.N. Day Homeopathy Medical College and Hospital since June 2020. Has worked as SRF in CCRS for 4.5 years until September 2023. Has published more than 120 research papers. So the today's topic is prognostic factor, research in homeopathy, and overview. So on behalf of Ifph, I am welcoming Doctor. You can have the platform for the next 45 minutes. It's all to you, sir. Please proceed.
Yes, today's topic is prognostic factor research in homeopathy and overview. So, prognostic factor is nothing but symptoms. So, we homeopaths deal with symptoms, nothing else. And this research is also about symptoms. What is remarkably different from clinical trials is that in prognostic factor research, we usually don't deal with p-values. We don't deal with samples. Rather, we deal with population, large population. It may be 2,000 or 4,000 in number, and it is preferably multicentric. Number of prescribers contribute in it so that any individual biases get dilute. This kind of research in homeopathy is only 25 or 30 years old. It started to emerge from 1990s. And now, after 30 years have passed, lots of researches have taken place across the globe, especially in Netherlands, Argentina, and also in India. And during the COVID times, number of data was contributed from India itself. And that resulted in a different kind of repertory I'll be discussing later on. So the thing is that this research is aimed at strengthening our instruments, not proving or disproving homeopathy, rather improving homeopathy. Clinical trials, systematic reviews, meta-analyses, all these things are aimed at either proving or disproving homeopathy. But prognostic factor research is targeted at improving homeopathy, refining our instrument, strengthen our instrument, so that the trials can be positive, so that the reviews can be positive, the meta-analysis can be positive. So it is a bit of complementary approach to each other, prognostic factor research, and this is Bayesian research, and another term is Bayesian research. This is one school of research. Another school is frequentist school of research. So this frequentist school and this Bayesian school, these are complementary to each other. So before going deep into this prognostic factor research, first we should feel the why this kind of things emerge. What was the necessity for doing prognostic factor research or symptom research in homeopathy? The problem lies in the repertories. We all know about these things, that repertory, there are different kinds of gradations in repertories. May it be 5 or 4 or 3, 2, or no gradations in repertories. This fact is well known. These are the repertories that have used 5 gradations. There are 4. These repertories have used 4 gradations. These are 3. These are 2. And some of the repertories and recent repertories like Barclay Square, they don't use any kind of gradation itself. Now, where from this concept of gradation comes? Kent says that if all of the provers or majority of the provers produce the symptoms, either in proving or in disproving, or the symptoms are verified in majority of the clinical verifications, then it is termed as first grade symptoms, isn't it? The second grade is only in few participants the symptom is found, either proven, either they are provers or they are sick people. And in third grade, the number is very few. The problem is, what is the majority and what is the few and what is very few? This is not defined. Some says that 51 is majority and some says no, 99 is the majority. So there is a huge area of controversy starting from 51 to 99, isn't it? So this classification should have been based on some mathematical formula. This necessity was not felt by myself, but rather Dr. Bonning-Hussen. I'll be showing you. See, even in Bonning-Hussen's or Boger's repertories, there are these are the gradation systems used, and these are their bases, similar to Kent. Here is another problem. If we, this is one described by Bonning-Hussen from his own practice. The case has been repertorized using BTPB. Okay. See, the first medicine is Valeriana that covers 21 rubrics and scores 58. The second and third remedies are Belladonna and Bryonia that covers 20 rubrics but scores the equal marks, 55 and 55. Now the question is, which one will be the medicine of choice? Whether it is Valeriana, which is much ahead in the number scored, or Belladonna and Bryonia, because Belladonna and Bryonia have covered same number of rubrics and same score. Obviously, being a teacher of repertory, I'll tell my students, you please refer to Materia Medica. Wherefrom, again, that is another source of subjectivity. Someone who prefers Valeriana will prescribe Valeriana, some will prescribe Belladonna, some will prescribe Bryonia. Then this is going to happen. But what is the truth? All three cannot be true. There is a single truth. See, this is the limitation of existing repertorization system, that they can't go beyond this much. Except shortlisting the most probable remedies, they can't help you in the final selection. Now the question is, can we go ahead of this step using newer techniques or newer research methods? Yes, the answer is yes. And today's session is about this, how we can go ahead with the existing principles of research and existing principles of homeopathy. Yeah, slides are not moving. Yes. The problems with existing repertories are that mostly the repertory entries are based on clinical verifications. Only a certain percentage is proving and reproving data, but majority of the bulk of the repertories are based on clinical data. That is observation in the sick. And all these observations are retrospective. That means, suppose how many number of sulfur patients you have seen in the month of November? Someone says, I have seen 30 patients. Now, by the nature of law, by the mother's nature, has made your mind in such a way that out of those 20 sulfur cases, you will be able to memorize only the 5 cases which are improved. And your mind is made up in such a way, you are bound to forget those 15 cases which are not improved with sulfur. When this practitioner shares his data, they share only the case those are successful. But what about the 15 cases which are not successful? Your mind is made up in such a way, we usually forget these failure cases. Our repertory is full of this kind of biases. That is recall bias. Okay, that is confirmation bias. There are different kinds of, we'll be discussing in another session. But, and another problem is that, which I just showed you, final differentiation is not possible among medicines which are under the same grade and scoring the same score. The basic reason behind this problem is that we use some medicines very frequently and some medicines very often. For example, if we go through the Kent's repertory, in the almost all the large rubrics contain the remedy sulfur. If we go to Morning Hussain, almost all the large rubrics contains veratrum. That means Morning Hussain used veratrum album or have seen veratrum album very frequently. That's why veratrum album is overrepresented in BTPV. Similarly, sulfur is overrepresented in Kent's repertory. But the less used remedies like the nosodes, these are very poorly represented in Kent or BTPV itself. So when a remedy is used very frequently, it gets some undue importance in repertory. It is overemphasized. The remedies which are less frequently used, they get less representation in repertories. But that should not happen. This problem was identified by Bonihausen himself. He told that in his preface, it is evident that in these classes, this gradation, there should be some kind of mathematics involved in it. But that could not be fixed for now, but need to be resolved later. This has been said by Bonihausen himself in his preface. The reference is given. Robin Murphy, being a mathematician, tried to solve this problem. He assumed a formula. If he get 12 cases from 3 practitioners, he marked it as grade 1. 6 cases from 3 practitioners, marked it as grade 2. 3 cases from 3 practitioners, he marked it as grade 3. But see, again, the problem of assumption. Why 12 cases, why 6 cases, and why 3 cases? Why not 24? Why not 20? Why not 15? So again, Robin Murphy also tried to address the problem, but somehow he was not successful completely in resolving the issue from a scientific or research point of view. But there was always a need for better repertories where all these kind of mishappenings could have been tackled scientifically. The answer lies in the principles of epidemiology. What are those? There should be a clear rule for constructing better repertories, and that rule should be reproducible, clear and consistent. The answer lies in epidemiology. As I said, it is in Bayesian statistics. Then the concept is named as likelihood ratio. Named as, according to the name of the great mathematician, Thomas Bayes. This is the man, and we call it as Bayesian statistics. But we have to keep in mind, he was not a homeopath. So naturally, his mathematics or statistics are nothing to do with homeopathy. It was actually applied for diagnostic research that deals with sensitivity and specificity. These are the very easy concept that we know from our very childhood days. Sensitivity means when the individual is truly being positive, the test identifies the individual as positive. And the specificity is when the individual is negative and the test identifies as negative. The concept of likelihood ratio merges these two concepts of sensitivity and specificity. The formula is very simple. Likelihood ratio is equals to sensitivity divided by 1 minus specificity. So it is a better expression than sensitivity alone or specificity alone. Likelihood ratio takes into account the both sensitivity and specificity. The interpretation is higher is the likelihood ratio, better is the diagnostic test. Say for example, if for a chest pathology, say for a lung abscess, you have got 3 tests to do. One is chest X-ray, one is chest X-ray, another is CT thorax, and another is some other test. Now, if we have to check what is the LR of this likelihood ratio of these 3 tests. The test scoring the highest, test having the highest error will be the best test for the disease condition. Similarly, this concept was applied in homeopathy. See, what was the earlier table? See, there was 2 points. One is diagnostic test and another is illness. Now we will be dealing with symptoms and medicines. This is the difference between diagnostic and prognostic research. Symptom present and medicine worked. Symptom present, medicine has not worked, and some other medicines were prescribed. That is section B. Symptom was absent, still the medicine worked based on some other symptoms. And lastly, section D, symptom was absent and some other medicine was prescribed. Formula for calculating likelihood ratio remains the same. And the interpretation is a symptom with higher LR is better indication for a medicine. Just like the interpretation of a diagnostic test. Higher was the LR, better was the diagnostic test. Similarly, higher is the LR, it is a better indication for a medicine. I'll be giving examples more. This is the tables, how the concept of prognostic research in homeopathy emerged from diagnostic research. Test has been replaced with symptom. Illness has been replaced with medicine. And this is the evolution. This table means that a test is better if LR is high. Similarly, a symptom is better if LR is high. So higher is the LR, better is the indication. As simple as that. Take an example. This is further clarification of this rest of the population. What does rest of the population means? This is an easy example. Suppose a patient comes with knee pain. And during case taking, we are going to calculate the likelihood ratio of egg desire for calcarea card. Now, there were 8 patients in whom we found there was desire for egg and calcarea curve worked in knee pain. That means calcarea curve was able to reduce the knee pain. There were 135 patients in whom there was a desire, but calcarea curve couldn't work. And we have to prescribe some other remedies. Section C, 18. There was no egg desire, but still calcarea curve was prescribed on some other indications like profuse head sweat, chilly patient, sweating of palms and soles, like this. This is frequently happening in homeopathy practice. For prescribing calcarea curve, there is no need that egg desire should be present everywhere. We can prescribe calcarea curve on other symptoms as well. And the last section, 839, where in these 839 number of patients, there was no egg desire and some other remedies were prescribed. See, what is striking, the total number of patients is quite large, isn't it? That is the basic difference between a trial and this prognostic factor research. In trial, we deal with samples. In prognostic factor research, see, we are dealing with population. A huge number, isn't it? Almost 1,000, 1,500, 2,000, like this. So, LR is calculated A by A plus C whole divided by B by B plus D. Simple mathematics. LR is 2.21. That means calcarea curves, egg desire, this symptom is having the LR of 2.21. This is an example, hypothetical example, just to make you understand. Now the question is, LR has been calculated, but how the problem of repertory can be resolved with this concept? Yes, there is a 4-step method. This is the method how repertorial problem can be analyzed or can be addressed. First is assume prior chance. Next, estimate prior odds. Next, estimate posterior odds. Next, estimate posterior chance. These are the 4 steps. See, in Bayesian statistics, always the prior chance starts with 1%. Clear? It is an assumption. In Bayesian statistics, almost all the calculations start from 1%. And gradually it goes up. See, whenever a patient is entering your clinic, the chance that calcarea curve will work is 1%. That is without any case taking, without any symptom. What is the probability that calcarea curve will work in this patient? That is assumed as 1%. That's all. This is step 1. What is step 2? Calculate the prior odds. This is the formula, chance by 1 minus chance, 0.01. This is prior odds. Step 3, estimate posterior odds. What is posterior odd? This is the Bayesian formula, LR into prior odds. Say LR, which can be calculated as I shown before from that ABCD table. Posterior odd is LR into prior odds. This is step 3. Finally, step 4, estimate posterior chance. This is the formula, posterior odd by 1 plus posterior odd. That is 9%. See what is happening. Forget this 4th step. Just remind the beginning. We started with 1% with a symptom that is having a known likelihood ratio. The chance goes to 9%. That is what I am trying to tell, that with addition of one symptom, the chance of selection of calcarea curve goes from 1% to 9%. This is called sequential update of chance. Just like what happens in our clinic. Say a patient comes with fever. With this single symptom, do we diagnose that the patient is having pneumonia? No, obviously no. We go on taking the case. We continue taking the case. Now we find that the patient is having cough, having rapid breathing, shortness of breath. So with addition of symptoms after symptoms, the certainty of diagnosing pneumonia goes high from 5% to 10%, from 10% to 25%, like this. Finally, after all the case taking and physical examination, chance of diagnosing pneumonia goes to 80%. Finally, the doctor prescribes a diagnostic test to arrive at a certain diagnosis of pneumonia. Just the same thing happens while we are selecting our medicine. When a patient complains of sore throat, the patient complains of halitosis, salivation at night, recurrent apnea, grinding teeth during sleep, chance of selection of mercurius gradually goes high. Just like diagnosis of pneumonia, similarly, prognosis or chance of mercury will work in this condition gradually goes high after addition of symptoms after symptoms. This is the prognostic factor research in homeopathy. That is symptom research in homeopathy. You go on adding symptoms after symptom, chance of cure gets higher and higher. So we all do these things intuitively in our practice, whether knowingly or unknowingly, we go on doing these things. Say, for example, this is another example. Say, from that ABCD table, we have in our database that egg desire has an LR of 10, profuse head sweat has an LR of 6, and chilly patient has an LR of 4. Now, if we find these symptoms in a patient, the chance of prescribing calcarea curve and getting a definite result goes, if egg desire is added, it goes to 9%. If the patient is having profuse head sweat, chance of cure with calcarea curve goes to 37%. If the patient is chilly, chance of cure gets to 72%. See, symptoms are added, chance of cure gets high. This is another real life exemplification. What is actually happening? We are dealing with 4 remedies: Rastox, Dulcamara, arsenic, and rhododendron. These are the 4 symptoms of which LR have been already calculated and we have already in our database. Now, when there is no symptom, chance of cure is 1 in all the medicines. Now, when we add motion ameliorates, chance of cure with Rastox is a little bit higher. Now we add another symptom, desire cold meal. See, Rustox goes far beyond dulcamer and arsenic. Same happens when we add another symptom, general sweat weather aggravation. See, Rustox goes higher. We add another symptom, heat vital lack of. Chance of Rustox is much higher than other three remedies. So, what can be concluded from this representation chart that Rustox is the sole remedy that will lead to cure in this case. So this kind of representation helps in tackling the cases without further going to materia medica. This representation sheet will lead you to the final selection. But no need to do this calculation, what I have shown you in my previous slides. All this will be done in software. What you need to do, just what you do right now, is to put those symptoms in likelihood ratio repertories. And the software will run all this calculation to show you something like this. This is how the likelihood ratio repertories look like. See, meet, desire, the rubric is this. Prevalence in the population is this. See, aconite, its likelihood ratio is 3.2, anacardium 2.4, basilinum 2.28, belladonna 5.43. It clearly means that belladonna is a better indication than all other remedies. See, picric acid is 4.07. So belladonna has a greater strength for this symptom than all other remedies. Obviously, the need for grading remedies, there is basically no need. The LR will tell you everything. Similarly, here is another repertory. Again, within bracket, the likelihood ratios are mentioned. Like, again, we have no necessity for grading into bold, italics, and Roman. During the COVID phases, a new COVID repertory has emerged. I have put in the link here. You can use it, just paste in your browser and open it, just try it. If you add symptoms after symptom, how progressive differentiation helps you in final selection of the remedy, you can easily get into that. This is a final evolution of the LR concept. I'm not going to discuss right now about this. This is how the LR repertories look like. So the chapter stomach, this is the rubric, and these are the medicines, and within bracket, likelihood ratio is given. Clear? You see, Veratrum album, these are the rubrics or symptoms of Veratrum. Say, for example, courageous. It has a likelihood ratio of 66.2. Fear of death, 31.89. Dictatorial, 24.07. All these have already been calculated. This paper was published in 2004. Again, Lycopodium clavatum. The symptoms are these: contemptuous, urinary stones history, egotism, dictatorial, and their LR has also been calculated. Similarly, Natramure, these symptoms have been studied: substernal fossa, lip crack, herpes, map tongue. These symptoms have been studied, 6 objective symptoms, and their LRs has been assessed. Similar things in case of Vinca minor. And see, already, as I've discussed, the major advantage is that there is a mention of specific numeric score along with each medicines, so that the medicines can be differentiated transparently. There is no misrepresentation in terms of gradation. And the accompanying confidence intervals means that this is an idea how the population statistics will look like. And therefore, as there is a little lesser importance of referring to materia medica again, so there is a definite control on the subjectivity in medicine selection. these researches are going on using the concept of likelihood ratio or prognostic factor research, whatever you say. And this is the man behind this concept, Dr. Lex Ratten. He is a converted homeopath, actually MD in medicine, practice of medicine, and based in Netherlands. All the doctors are in Netherlands who are contributing to likelihood ratio are working in association with Dr. Lex. And he has also visited India a couple of times. And for further reading, you can refer to these two books. The first one is published by BGen. You can order it online. The second one is available in CCRH website. So that's all for today. It's a huge thing that we are dealing with, likelihood ratio. Again, I'm telling that likelihood ratio does not deal with samples that you get 30 or 40 patients or 50 patients and do a likelihood ratio analysis. We are dealing with 2,000, 4,000 patients for validating a single rubric. It takes 3 to 4 years time to get the scientific, that amount of scientific data. And there are different scales we use in this research, which I could not discuss today due to time constraint. One is Glasgow scale, another is Naranjo. And finally, likelihood ratio data is given or contributed by a number of practitioners. So if there is any individual bias, that may happen, that may occur, obviously, that can be diluted in that much of data. Okay, so that's all for today. This concept is relatively new. Not much researchers are working on it. Only a handful of researchers are there who are working on it. We are also trying to do something from our college. Maybe in coming 1 or 2 years, we'll be able to publish the papers. We are not only trying to validate the medicines enlisted under different rubrics in Kent, like sympathetic, ascending, upstairs or downstairs. And also, we are trying to validate some symptoms from Materia Medica of some polycrest remedies, major remedies. Let's see what happens, what happens in future, how much the LR comes. And definitely it is a time-taking process. For every symptom, we are assessing around 2,000 patients. So that's why it is a much laborious job, much time-taking job. Thanks for today. Thanks for offering this platform to convey my findings. Thanks.
Yes, thank you, Dr. SUBHRANIL SAHA. It's a wonderful and interesting one, as well as quite novel to us, as far as I'm concerned. Anyway, nice presentation. A lot of discussions is needed. A lot of effort is needed. You just said about studying the symptoms around 2,000 patients plus patients is not an easy task. I think this is one of the most extensive research work done in the history of medicine, I think. Most interesting one, most honest one, I think. It's time for discussion. Those who would like to participate, please go to the participant list and you can raise your hand. Around 20 plus minutes remaining. A really remarkable topic. And this is a fitting reply to those who are often criticizing homeopathy. There is no studies, no research works, no substantial research works. But you just go through the through the repertories. From the Ken's repertory to the Murphy's repertory, you can see the collection of data, how extensive was the studies. Each and every medicine is studied in the human beings and evaluated. Then again, the symptoms are, the gradation is there. Now it is progress to the likelihood ratio. It's also a wonderful transformation. Dr. Mudul Sahani, sir, what is your opinion, sir?
Very nice presentations. I had been listening in the Hindi session also, this same talk. What I will like to say, Dr. SUBHRANIL SAHA, he is associated with the research work since long. I know him since long, and he was he now presently the very prestigious college at the D&A college, and I have seen his work personally also, that what type of the labor he do with the patients and as well as the students, and with And with this, he is getting the fruits of 125 publications already published in the peer-reviewed journal. Just for the very, this speaks about the acceptance in the scientific arena about Dr. SUBHRANIL SAHA. Dr. SUBHRANIL SAHA has a lot of research aptitude. In our last two sessions, he has also given session on the clinical trials. He has spoken on the research trials. And his fourth session will also be there on the next Sunday on the 10th. So all these things are meant to educate the homeopathic practitioners that we have to cooperate unless each and every individual, because you have just, Dr. Manoj, you have told that there needs a proof about the scientific city of the homeopathy. We have to tell the science that we are scientific. And this is possible only when we have the cooperation. Yes, few people are doing, Dr. SUBHRANIL is doing, and some others are doing. That is not enough. They need the support and cooperation from the entire practitioners. And all must have the research aptitude, because Dr. Harriman himself is a case taking, a long process, and
Okay, sir, kindly,
sir,
Sahani sir, please take some rest, sir.
Yeah, I'll take
We'll
some
come to you
rest.
later. Don't worry.
I'll continue later on.
Yes, sir. Now, Dr. Veena, are you there? I think you are interested in all this topic, Dr. Veena.
Sir, namaste, sir.
Yes, please.
Actually, I joined just now,
Yeah.
a bit late, but I have seen the presentation PDF in the group. So is it the same? Is it the topic the same?
It's a continuation of the earlier days program, and it is based upon the likelihood ratio. Subhanil, sir, doctor.
Yes, I have already shared the presentation.
Yeah. So it is interesting. Even I was going through that Natrum muraticum and other remedies. How it's a retrospective statistics, which was what I understood. It's a great thing, sir. So really, we need to update ourselves by doing research.
Yeah, but one thing to be very much aware of, likelihood ratio as recommended is should always be prospective. Okay, and doing retrospective estimation always incorporates some kind of biases, and it is always recommended to do prospective research. Okay,
Okay.
so some sort of researches are already ongoing in a retrospective way, but we should not be continuing this. And definitely we should plunge it into prospective research, prospective data collection.
And I have a suggestion also, sir. See, why don't we, the homeo colleges, tie up with the statisticians or PhD students and give some of the data and ask them to, means real-time data, let them come and record, everything is okay. But is that as a possibility? And can we have a tie-up, means any colleges, for that matter, interested colleges can do a tie-up with the PhD ongoing batch or something, so that since they have the expertise, let them collect the data and do some research on that. Will it be helpful? And can this be suggested to the colleges?
A good idea and good suggestion. Actually, likelihood ratio research is like that. It should be multicentric data collection that increases the validity and reliability of the data itself. And as I said earlier, we are dealing with population, because likelihood ratio has very little to do with inclusion and exclusion criteria. Likelihood ratio is not concerned about samples. All we deal with is population, large data, multicentric practitioner, routine practice. So there is no foundation for filling in forms after forms, just happens in clinical trials. What is happening in likelihood ratio research is to continue your routine practice but more consciously, prospectively, and honestly, so that we can contribute to the ever-growing field of data only by prospective research. And again, I'm emphasizing on the point, not retrospective. We should be contributing by prospective research only. And yes, obviously, if a tie-up or a collaboration or a MOU can be signed between colleges, it will help us immensely in data collection. And also the data will be much refined as of now. Our PGs are already involved in this kind of tasks, and they are already sensitized, and I'm taking regular classes of them. And if it can be done on in a national level, that will be much better, obviously. Thank you for the suggestion, and I would like to always collaborate with any colleges they are willing to cooperate. That's all. Thank you.
Yes, thank you,
Thank
Dr. Bina, for actively
Dr.
participating in discussion. Yes.
Dr. Manoj.
Sahani sir, are you ready?
Yeah. I want to add in this reply that collaborating with the colleges, the Central Council for Research in Homeopathy has recently started collaborations and taking with the different colleges, all the colleges. So PG colleges should join and have a collaborative process has to be developed, collective process, what Dr. SUBHRANIL was telling. And there are the guide, they are always ready to guide. SUBHRANIL is very open to guide all the colleges. So colleges must come forward and undertake this, because this is their opportunity. They have the opportunity for the large number of the practitioners, students, as well as the clinics. So this is possible. So I think we have to spread this message, and the colleges should come forward first so that it can be completed.
Yes, sir, that's the great thing. And I think we need much fresh courses to improve the education in homeopathy. Then only we can have a formal course is needed. Unfortunately, that is not happening after the PhD courses. Only 3 level is there: the degree level, then the post graduation, then postdoctoral. No more courses are there in homeopathy. Now, Dr. Narayana, are you there, Dr. Narayana?
And Dr. Kurup has also joined. So he will also be a better person.
Not joined.
Dr. Kurup has also joined now.
Yes. Sridhar Kurup, sir, are you there?
Yes, what is the subject? Because I was in another meeting. Sorry. What is the subject?
Okay, sir. The prognostic research, factor research, sir.
Yes,
And the likelihood ratio.
After I worked with that about more than 30 years in the research, and my experience was that about 47 years as a clinical experience and teaching and all this together, that I feel that research is the need of the hour, but that, of course, the Central Council is doing so many things that it is not coming out that much what we are, all the others are expecting. Of course, they are doing so many things, but we are not knowing that the what I feel is that the fundamental research is most important than that of the treating the old patients and keeping the patients and again and treating that we know. All other diseases are curable. That disease, again, research means research. Again, search and find out something is new is there. Some new data also we must have to analyze and find out the new ideas and how it works. Not only evidence-based, that new ideas. Some people are trying that I know. I was there, but so far that is why these other system people are always telling it is not scientific. It is not scientific. We are not having correct answer for that. There we fail. Of course, we are having result more than that of the other system. It is quite true. But we must to find out how it acts and how it works. Of course, we all know
Yes,
it is
sir.
evidence-based. But that we must have to, the government must have to initiate such, and if we may not able to do it, other
Yes.
scientists, we must have to give aids to them, support them, and they will find out it's how it acts, and not that we when we may saw the history of to the scientist, that we saw that Edison and so many person, they are invented so many things, not with the education and these things outsiders. And even our born cousin, he was not actually a learned person, but he was having sufficient knowledge. So outsiders also can try. And in there is a syllabus in that the Bombay Pune University. There one Chandran is there. His book is that in the syllabus is it is there for learning. How it is selected? He is not at all like homeopathy. So he is an outsider, but he learned the homeopathy and he explained that it is in the curriculum. They are included that book also. So if we cannot do it, that I was just that I came from another meeting, not homeopathy, that some other public meeting. There we are talking about that if we cannot do it, we must have to
Okay, sir.
think to the others also. Thank you very much.
Yes, now Dr. Veena, please. You can unmute now. Continue, Dr. Veena. Yes.
Yeah, I have one more suggestion, like
Yeah.
how the allopathic medical school has got non-clinical branches like microbiology, pathology, and all that. We can also introduce something with homeopathic branches and train the doctors so that they will be helpful in collecting the data, taking the case, and maintaining the data and all those things. We can involve, and it will create more awareness in the public about homeopathy. And probably tomorrow we will get more job opportunities also. Thank you, doctor.
That's also interesting one. Then definitely there are fellowship courses are there, but it's not yet to start in homeopathy. But Ayurveda has done a lot of things in that way. But homeopathy yet to begin such initiatives. Now, anybody would like to participate? Please raise your hand. Dr. Narayana, are you there? Dr. Narayana. He's not responding. Now, Norlisa. Dr. Norlisa, are you there?
Dr. SUBHRANIL Shah is there.
Pardon?
Dr. SUBHRANIL.
Yes, he is the guest. He's the guest doctor.
Okay.
Yeah. So what is the main problem is that the work done by the Central Council or the CCRS is not at all even referred in our colleges, in hospitals. Nobody is bothering, nobody is even referring. That is the main problem. Dr. SUBHRANIL, what is your opinion? Majority of our students are still ignorant. Not only students, but teachers are also ignorant. The volume of work they are doing. Dr. Saha, what is your opinion?
Pardon?
What is your opinion, Dr. Saha? The institutions or the colleges or the teachers are not even aware what are the things happening or doing in the CCRH. The research.
See, when the problem is identified, it depends on us whether we are actually trying to solve it out. Many problems raised in this discussion only and answered in this discussion also, that we should develop a uniform teaching portal where from all the PG colleges or the colleges running PhD courses, they should have a uniform teaching panel so that these things, say for example, this likelihood ratio research, it can be taught or sensitized to them thoroughly what is going on and what they need to do to contribute this kind of research. If that plan can be disseminated, and it is not possible for us to go to every college and teach every student over there. But
Yes.
what can be done? If make all the colleges agree, come under a common platform, say like a Zoom platform. We'll be holding up training sessions at a scheduled time. All the PGs or PhD scholars should be attending those sessions, and things can be sorted out very easily. Be it not only prognostic factor research, how to doing a trial, how to frame a research question, how to do a hypothesis testing, how to write it out, how to write your synopsis, how to write your final dissertation. Everything should be unique and homogeneous throughout all the PG colleges so that there should not be any confusion. What I see that lots of research, especially be it in the name of ST. I am talking about colleges only. I am not talking about CCRH. Whatever research are being conducted, lots of STSH proposals get approved every year. Students are getting involved in research. But where does those researches go? Out of 350 or 450 approved proposal, only 1 or 2 getting published. The tagline is, if a research is not published, it's not a research. You are doing a research, but you are not able, or you even don't know that you have to publish it. You don't know where to publish. You don't know what is a scientific journal, what is a predatory journal. You may be doing a 10 years of hard work, and ultimately you waste your work by publishing in a predatory journal. It doesn't get indexed. It does not get counted in scientific community. So all these are problems lying with homeopathic community right now. And there are 3 ways to solve this problem. 1 is training, 2 is training, 3 is training. You get sensitized what is going on. You get sensitized how to do a scientific research and simultaneously maintaining the principles of homeopathy, and you get trained where to publish and how to publish. That's all.
Yes.
So every problem, every question has a specific answer. It depends upon us whether we like to listen to it or not. Or we are just gobbling up degrees. We are named as MDs and named as PhDs, but we are not contributing at least to research or science.
Yes, so the most important thing, just like our medicines or remedies, the sensitization is the sensitivity is the most important factor, and we must will be sensitized. I hope in the coming days, the Central Council or the National Homeopathy Commission will also think or work on that way. And starting to wind the session, may I invite Dr. Veena to make an evaluation as well as express word of thanks to Dr. SUBHRANIL SAHA, please.
Yeah, regarding this little bit of addition, NCH is probably thinking in this way. They are coming up with this kind of orientation programs. There will be there may be a panel of trainers so that uniform education or training can be imparted to the PGs or PhD scholars. Let's see what happens in near future, because new department, new faculty of biostatistics and research methodology is being framed. Proposal is ongoing. And let's see, maybe coming in 1, 2 or 5 years, something positive will be happening.
Yeah.
And this kind of vagueness, what is prevailing right now, that CCRH is doing this kind of thing, but we are not aware of that. CCRH is not doing up to the mark. Why are we always looking up to CCRH? Is not it our the responsibilities of the educational institution to contribute to research? Why should always CCRH will be doing? Why should not we? Are not we capable enough to do research?
Yes.
Definitely, it is true,
Yes.
very much true.
Yes, time to say the vote of thanks. Dr. Veena, please proceed.
Yes, sir. So a great thought-provoking last question asked by Dr. Sir. Actually, see, each one, like as a homeopath or as a citizen itself, we each one are have to take the responsibility so that we evolve, we get trained, we get the experience, right experience from the right people, and evolve further and make a great impact on the science. Congratulations, Dr. Sir, and we are very thankful for you for coming to the platform and giving such a nice insights, actually, which many of them are not aware, actually. Thank you so much, sir.
Yes, one thing important is that almost all medical colleges, the department, each and every department is connected or provided with a research professor in biostatistics and research. But unfortunately, we don't have